Okay, so welcome everyone. Welcome to our quarterly nutrition rounds where we discuss a case and in a medical rounds type of manner. We will have Dr. Friedman present a case today, and I will introduce him in a little bit, and then hopefully we'll have time for some friendly discussion on how medical nutrition ties into this particular case. So I want to introduce first our panelists. We are honored and humbled to have three amazing panelists today joining us. The first is Dr. Saba Kovesti. Dr. Kovesti, and I'm going to read this, is currently at the University of Tennessee Health Science Center, where he is the Fred Hatch Professor of Medicine and Nephrology, the Director of the Clinical Outcomes and Clinical Trials Program in Nephrology, and the Medical Director of the Clinical Trials Unit. He is also the Chief of Nephrology at the Memphis VA Medical Center in Memphis, Tennessee. He trained in Hungary, Detroit, and the Johns Hopkins University in Baltimore. Dr. Kovesti's research interests are centered on disease mechanisms and outcomes of patients with pre-dialysis, chronic kidney disease, and end-stage renal disease. His research involves clinical trials, observational analyses of large administrative databases, and translational research experiments in patients with all stages of kidney disease. He is a fellow of the American Society of Nephrology and a member of the International Society of Renal Nutrition and Metabolism, among others. We are also joined by Dr. Anderson, his colleague at Indiana University. She's a board-certified transplant nephrologist and an associate professor of clinical medicine at Indiana University School of Medicine. She trained at Southern Illinois University and Indiana University, and her clinical interests include acute renal failure, chronic kidney disease, end-stage renal disease, glomerulonephritis, and ethics. She is a member of the American Society of Nephrology. And last but certainly not least, we are joined by our own David McCarran. Dr. McCarran is also a board-certified nephrologist, educated at Williams College, UPenn, Case Western Reserve, and Tufts, with a brief stop in Haiti, which sounds amazing. He is an internationally recognized expert on dietary nutrients and cardiovascular disease, and his early work helped shape the foundation for the DASH diet to treat hypertension. For most of his career, Dr. McCarran was at the Oregon Health Sciences University, from where he retired in 2001, but he continued his work at UC Davis and retired a second time in 2018. In 2004, he received the International Award for Modern Nutrition for his contribution to the role of nutrition in human hypertension. Dr. McCarran is a fellow of the American Society for Nutrition and a founding member of the board of the American Society of Hypertension. He also served on the board of directors of the American Society of Nutrition and has chaired its Medical Nutrition Council. We are humbled and proud to have Dr. McCarran serve on our board of directors as an at-large representative, and honored to have him and both Dr. Kovesti and Dr. Anderson join us today as panelists for Dr. Friedman. And just briefly for Dr. Friedman, he is an associate professor of medicine at Indiana University. He also trained at Tufts, as well as the U.S. Department of Agriculture Human Nutrition Research Center in Boston before joining Indiana University. Dr. Friedman's research interests are on topics related to the overlap between nutrition and kidney disease, and he has received grant funding from the NIH and the National Kidney Foundation, among others. He served on the editorial board of the Journal of Renal Nutrition and Frontiers in Nephrology, and has played a leadership role at the American Society of Nephrology and the American Association of Kidney Patients. He is currently a council member of the ISRNM and is organizing the first ever multidisciplinary conference on management of obesity in kidney disease that will be co-sponsored by the National Kidney Foundation and the Obesity Society. To be perfectly honest, it was Dr. Friedman's interest in cross-pollination and collaboration across medical specialties that was instrumental in our development of this quarterly event. I encourage all of you to please speak up, contribute, and remember that passion that drove all of you and all of us to patient care and medical nutrition. So with no further ado, Dr. Friedman, the floor is yours. Thank you.
Oh, thanks very much, Daron. I appreciate the invitation very much, and I'd like to thank the BPNS for the invitation, and of course all the panelists. And I'm glad that some people are interested in hearing perhaps some renal oriented nutrition cases. So the first case, well, actually the first and only case today, which I've entitled 2 Strikes and She's Out. So let's begin. So this was a patient who presented to me several months ago, a 66-year-old white female who came to my clinic for evaluation of severe hypomagnesemia that caused a delay in planned surgery to remove her breast tumor that she had, and she was referred by her treating oncologist. Her past medical history included type 2 diabetes for at least 15 years, a resistant hypertension for at least 18 years, breast cancer for which she recently actually completed some chemotherapy. She, excuse me, was a retired insurance clerk, lived alone, and denied any history of tobacco, ethanol, or illegal drug use. In terms of family history, she did have a family history of breast cancer, but no history of electrolyte issues that she could identify. And here are her list of home medications. Alendronate for bone health, and then she was on several antihypertensive medications, including amlodipine and a combination lisinopril, hydrochlorothiazide, doxazosin, and metoprolol. She was on Prilosec over the counter. She had previously been on Prilosec BID that was prescribed. Now, I'm not exactly sure what happened, but she was currently taking the over-the-counter type. She was also on several vitamin and mineral supplements, including calcium carbonate, Centrum Silver, vitamin B12, vitamin C, vitamin D3, magnesium chloride, and potassium chloride. So this is her HPI. This is her presentation. In looking back, I found that prior to 2020, she actually had several magnesium levels drawn, and they were all normal. In 2020, she had one magnesium level that was checked. I'm not quite sure why. And it was borderline low, 1.4 milligrams per deciliter, where the cutoff is 1.6. And as I said, there was only one check that year. In January of 2021, about half a year before I saw her, she began weekly Taxol therapy for her breast cancer. And it was complicated by some weakness, headaches, and loss of appetite. 3 months later, she actually was found on incidental lab testing to have a magnesium of 0.6, and was admitted promptly to the hospital, where she was treated with intravenous magnesium and released. And 2 months later, came back for the same reason, an incidental finding of hypomagnesemia, severe hypomagnesemia around the same level, for which she continued to receive intravenous magnesium therapy. It's interesting that she never really presented with very severe symptoms, as far as I could tell from her chart. It sounded like her symptoms were primarily headache, but again, just incidental findings of this life-threateningly low magnesium levels. Between June, when she was discharged from the hospital, and several weeks later when she saw me, she was getting frequent IV magnesium infusions to keep her magnesium level up. In terms of a review of symptoms, she was generally feeling fatigued and noticed that her appetite was poor. She was very clear about that. Really wasn't eating much fruits and vegetables. She said she ate lots of meat. I wasn't sure whether or not to, how exactly to interpret that, and whether or not she truly was eating a lot of meat. But she also noted that she in general avoids dairy. Okay, so at that point, I'm seeing her towards the end of June 2021, and the two questions that I felt I needed to address were, number one, why does she have a borderline low serum magnesium level the previous year? And number two, why did the serum magnesium level significantly worsen in the several months prior to me seeing her? And whether or not these were, and the third question, which I didn't include here, but which I also considered was, were these two related? And I assumed that there was some sort of relation. So you can see here, here are her serum magnesium levels starting in April 2021. You see the the presentation level of 0.6. She was treated with IV magnesium infusion, then came back a couple months later, actually, again with a level of 0.6, and was treated, was discharged, and then saw me. At that point, her magnesium level was 1.9. So that's sort of these are the serum magnesium levels just prior to seeing me. So let's step back for a second. What I'd like to do right now actually is, and Doron, I don't know, is this, do I ask for questions at this point, or would you like me just to continue throughout and then field questions at the end?
I think it's a good idea to maybe pause and ask if anyone has any questions at this point.
Sure. Yeah.
And please forgive the noise. I did not expect construction in this room.
No, so yeah, so if anyone, I don't know if anyone has any questions or thoughts at this point, I'm happy to field them without giving away the, you know.
So Alan, it's Dave Karen in Portland. What is the precise timing of her Taxol therapy? And I mean, you alluded to it, but did this all definitely come on after she was treated?
So
and she's still being treated.
So what I found was that the final Taxol treatments were in January of 2021. And that's when she during that period of time, that's when she had symptoms of fatigue, weakness, and a headache and loss of appetite. And then it was 3 months later when she presented with the severe hypomagnesemia. And she was treated with Taxol therapy.
But it was stopped.
It was stopped. Yeah, she had completed her treatment regimen in January of 2021. Okay. So the mild hypomagnesemia level, the mildly low level of magnesium that was measured in 2020, the year prior, was measured prior to any chemotherapy. But the more severe presentation of the hypomagnesemia occurred 3 months after the end of her Taxol treatment.
Okay. Thanks.
Okay.
I have a couple of questions from Dr. Xiaoping Li. She's asked if, I think she's asking if she drinks alcohol, and then she was wondering about some symptoms such as diarrhea.
Yes, excellent questions. She denied alcohol use and denied diarrhea. A very appropriate question for someone for evaluation of hypomagnesemia, since diarrhea can be lost in the stools.
And I have a question about her blood pressure. Were there any blood pressure lability?
What do you mean specifically?
Blood pressure that is labile, that is
okay. Not that it was ever recorded, and I don't remember the exact blood pressure when she first saw me, but it was not. I did not know upon review, and that wasn't my main focus. But upon review, there did not appear to be any lability that I could identify.
Can I ask something, Allon?
Of course. So, yeah, sure.
No, thank you. So I usually think about magnesium similar to potassium. You know, us nephrologists like to put things in boxes and sort things out mechanistically. So it's usually decreased intake or absorption, redistribution, or excretion to make it easier to understand. So I have a few questions about additional workup, if it was available. Has she had at any point her urine magnesium checked, or a fractional excretion of magnesium to separate urinary losses from other type of etiologies? And do you know, or do you remember what her serum potassium was? Since oftentimes magnesium and potassium deficiencies go hand in hand, and sometimes it's difficult to disentangle what causes what. And I noticed that she was also receiving potassium supplements. So I suppose she had been hypokalemic at some point. Yes.
So she did have a urine magnesium check, and I will be getting to that. She had been hypokalemic in the past. But when I saw her potassium level was normal, it's just on very low levels of potassium supplementation.
Thank you.
Okay, so why don't I move on now? And what I'd like to do briefly is review magnesium handling. So, excuse me, there we go. So just as an overview for everyone who's listening, the daily magnesium intake is approximately 360 milligrams on average. It should be noted that bone is a major reservoir for magnesium, and I'll show this in just a minute. In healthy people, there is generally no net gain or loss from bone. So the magnesium balance in the body is achieved by urinary excretion of what was absorbed from the intestines. And another important point to consider, excuse me, which Shaba sort of alluded to, which is that magnesium homeostasis is controlled by the kidney. So it's important to know what's going on in terms of magnesium handling within the kidney, because the ins and outs of magnesium are really balanced very much by, or fine-tuned in the kidney itself. And here you can see in this figure basically what's going on. So we start with daily dietary intake, 360 milligrams, okay, absorbed in the intestine, 260 milligrams of which, of the 300 milligrams, is excreted in the feces. So we have 100 milligrams that have been taken up in the blood compartment. Now, as I mentioned, because bone is the principal reservoir of magnesium, and bone doesn't readily exchange with the blood compartments. Excuse me. It is really kidney handling that fine tunes the magnesium level in the blood. So problems either with kidney handling of magnesium or absorption of magnesium will lead to low levels within the bloodstream. And so let's turn to her. So the questions here are, what is the source of the low magnesium in her? And as was mentioned, the kidney, can be a possible source. If there's a kidney, what nephrologists like to refer to as a kidney urinary leak of magnesium, that can lead to a low magnesium level. Now, how do we know whether or not there's any appreciable loss of magnesium through the kidneys? Well, we check what's called a fractional excretion of magnesium, which is basically the ratio of urine to serum magnesium over urine to serum creatinine. And if the percent is less than 3%, when the serum level is low, it suggests that the kidney is actually holding on, working appropriately to reabsorb all filtered magnesium. And it turns out that her kidney was actually working the way it was supposed to, and there was very little magnesium lost in the urine. So if the kidney is not the source of the low magnesium, then we have to look at uptake. And uptake there are two aspects to magnesium uptake. One is dietary magnesium consumption, that is how much magnesium is being consumed by an individual, and then how much is being absorbed in the gut. And when we look at magnesium absorption in the gut, and you can see here in the schema here, we have the magnesium on the left side. It's being taken up by enterocytes by a transporter called the TRPM6, TRPM7 also. And it can also be absorbed between the cells, so-called paracellularly, and then is taken up in the portal vein and distributed throughout the body. It turns out that the TRPM6 transporters also, TRPM6, TRPM7 transporters are also found in the kidney as well, in the distal convoluted tubule. So as to question number one, by the way, any questions at this point? Any further questions? Okay. So in terms of question number one, why did she have a borderline low serum magnesium level in 2020 before she was treated for her chemotherapy? Well, I suspected that she may have had reduced intestinal absorption due to the proton pump inhibitor that was started the year prior. Now, it turns out that about 5 to 10 years ago, there was a number of studies that found an association between the use of proton pump inhibitors and hypomagnesemia. And while the mechanism may not be completely understood, it appears that at least it's hypothesized that the PPIs disrupt these channels, the TRPM6 and TRPM7 channels, that funnel magnesium through the enterocytes into the blood. So that may have explained her predisposition towards a low magnesium level to begin with. Question number 2 is, why did the serum magnesium level get much worse in just 2 or 3 months after her Taxol therapy? I thought that it was probably related to a sharp decline in food intake after a chemotherapy regimen. And because she was already predisposed towards reduced absorption because of the proton pump inhibitor, further reducing her dietary intake may explain why her serum magnesium levels dropped to dangerously low levels, because she basically had 2 hits. Not only did she have decreased intake, but she also had decreased absorption. And it should be noted that they treated her with intravenous magnesium over April through June, but that's a challenging way to treat hypomagnesemia because it washes through the body fairly quickly. So these patients often need a subcutaneous port in order to get these intravenous infusions, and they need frequent infusions. And it's a mess, and it's very challenging to treat severe hypomagnesemia effectively this way. So when I saw her, that was after thinking about this process, excuse me, I performed a couple of medical interventions. And the first one was stopping the proton pump inhibitor, right? A no-brainer at that point. The second one was to encourage her to improve her dietary intake and to start her on magnesium supplements. The supplements that she had been on were over the counter, and I believe I used sort of a SLOMAG, a magnesium chloride regimen, which is sometimes more tolerable to people because it causes less diarrhea than the magnesium oxide that is used, that is not absorbed as slowly. So that was the second point. And the third one was I did stop her hydrochlorothiazide, her diuretic, even though the fractional excretion of magnesium suggested that she wasn't losing any magnesium in her urine to a significant extent. I still thought it would be best to stop this because this can lead to additional loss of magnesium. And this is the pattern. So my visit was here with her in June 30th of last year. We stopped the medications and added magnesium, and the magnesium did remain within the normal range. During this period, I then sort of slowly tapered off her magnesium supplementation. And, by the end of July, August, she was basically off of them and was able to undergo her breast surgery for which the surgeons and the oncologists were waiting on. And our last visit, the last measurement was in October, off of everything after a couple of months of being off of everything. And at that point, again, her serum magnesium remained within normal limits. So I was able to identify the causes and resolve them to a sort of in a successful manner. And I haven't heard anything since then, so I'm presuming that her magnesium level is still within the normal range. So just a couple of takeaway points here. I mean, there are a number of takeaway points, but the ones that I just wanted to mention in ending is that, number one, when the patient's kidneys are working the way they're supposed to, that is, they're reabsorbing all the magnesium that is filtered, we really need to look at impaired GI absorption and reduced oral intake as causes of magnesium, of hypomagnesemia. On that note, however, it should be noted that magnesium is a fairly ubiquitous mineral. That is, it's found in all sorts of foods, a variety of plant and animal foods. So you'd really have to have, and even in beverages, and even frankly in the water system, in public water systems, magnesium levels, trace magnesium can be found in our public, the water we get from our faucets every day. So in order for someone to develop significant hypomagnesemia, you really have to reduce your oral intake to profound levels. This is not just a mild reduction in dietary intake or just not consuming one food group or another. it has to be sort of more of a global process where they're really profoundly anorectic and not consuming foods. So I think, so that was my last point, and I'm happy to discuss or, take any further questions or discuss any other thoughts that anyone may have at this point.
Wonderful, Dr. Friedman. Thank you so much. Excellent presentation. And, as physician nutrition specialist, magnesium certainly comes up. It comes up with a more holistic approach to medicine. Patients that use magnesium for muscle cramps and to help them with blood pressure, or those that have chronic diarrhea or constipation. Usually it's more constipation, and the magnesium is a bit of a cathartic, but that's dependent on the form of magnesium. But magnesium is a smooth muscle relaxant. We use it sometimes in asthma cases, status asthmaticus. So it does come up, I think, for clinicians who practice medical nutrition. So it's a very relevant topic, and I would love to open it up to our panelists to hear from our distinguished panel who are nephrologists. How often do you see hypomagnesemia, and in what setting does it come up?
Well, Doran, is David. I think it's more common than people realize. And in part because it's like other things in medicine, it gets overlooked because of more dominant things we think about in terms of electrolytes and metabolic balance. In my experience, the vast majority of people I saw with hypomagnesemia were because of diarrhea and whatever provoked that, and it was fairly long standing, so it didn't happen overnight. And you also, as Dr. Friedman pointed out, you typically see in a lot of these patients hypokalemia at the same time. So another thought is, if you see somebody with hypokalemia and you're not sure why they have it, make sure you measure magnesium, because the two move together. And I'll stop with just saying, I saw a woman probably 10 years ago that was referred by a community nephrologist, a good doctor, who could not explain her persistent hypokalemia and change in her mental status. I mean, she was a bizarre person and had not been. She was an athlete, ran all the time. And as it turns out, she was on such a depleted diet of electrolytes that, because she had a number of occasions, she had a urine sodium that was undetectable, which is almost impossible to have given the human diet. And to the end, I could not really figure out what she was eating, in part because you couldn't talk to her. But she had a whole spectrum of problems, and was obviously quite ill. And she wouldn't come back to see me. I mean, you couldn't talk to this person. So this discussion is very helpful to practicing clinicians. The magnesium's on a chart. Most people don't think about it, so if it's a little bit low, you don't do too much about it, but you need to be thinking about it.
Dr. Anderson, yeah.
Yeah, I really like this talk. I think it's a really good topic. At Indiana University, I did a lot of work with liver patients, both before and after liver transplant or liver kidney transplant. And when somebody has cirrhosis with a lot of abdominal distension, they don't eat. And you end up with a lot of electrolyte imbalance. Magnesium was one of those, sodium is another, and their fluid balance would be off because they wouldn't eat their electrolytes. But the problem was, after transplant, you couldn't get the magnesium levels up because of medication, and they had to learn how to eat again. So I really think this is an important topic. And I think it opens a door for non-medicine therapy, which patients really appreciate, especially after a transplant, when they're taking handfuls of drugs. And so this is a really good topic. I like the explanation of the physiology as well. Very important.
Thank you, Dr. Anderson and Dr. McCarran. As a gastroenterologist, we use PPIs all the time. I was a little surprised to see that this is not a dose-dependent mechanism. Her PPI dose was not out of the ordinary. 20 milligrams is the usual dose. And do you suspect that she has some kind of a genetic underpinning that predisposes her to PPI disrupting her absorption of magnesium?
I don't know. I don't know. I'm not. I don't know if any of the other panelists are familiar with the literature in this area. I haven't heard that. I mean, obviously we have a lot of people, the vast majority of people on PPIs that do not become hypomagnesiemic. So maybe there is a predisposition that's genetic.
Yes, so this whole physiology of magnesium metabolism is really much less clear, I think, and came about much later than what we knew about things like potassium and sodium metabolism. And my understanding is that even the transporters that Allon, you mentioned in your talk, in the gut and in the kidney, they were late discoveries based on genetic mutations and families who came with profound hypomagnesemia. I agree, Doron, that it's quite possible that some of these, and especially PPI, may be related to some genetic predisposition. But just like you, Allon, I'm not familiar with any clear evidence towards that. And by the way, even the PPI-associated hypomagnesemia is a discovery that was made in the last 10, 15 years.
Yeah.
I mean, in my fellowship, we didn't learn about this. I learned this about later. I'm just giving away my age, of course.
And you're a young guy. Well,
I just look young.
No, I think the papers came out maybe in the last 5 to 10 years.
Right.
So it's a fairly new problem that's been identified. And I don't know, Doron, do you see, as a gastroenterologist, do you see hypomagnesemia in your patients with inflammatory bowel disorders, enteritis, or bacterial overgrowth? Do you see this type of thing frequently?
I actually like checking magnesiums in my patients, phosphorus and magnesium, along with my comprehensive metabolic panel. And
you should have been a nephrologist. You should have been a nephrologist.
Yeah, well, I like seeing, well, first of all, magnesium, I think, like potassium, is mostly intracellular, is it not?
It is, but
compartment, yeah.
It is, yeah.
And we treat, as gastros, we treat with a lot of proton pump inhibitors at very high doses sometimes. And I do check, and I don't see such a severe hypomagnesemia of 0.6 milligrams. And we were taught during fellowship, I think Dr. Anderson mentioned that some of the, like tacrolimus is a medicine that tends to waste magnesium. We would see magnesium levels maybe fall to like 1.3, 1.2, 1.1. Rarely did we see it go less than 1. And we were always taught to be careful because the patient may have a seizure. So we were chasing magnesium levels in our transplant patients who are being treated with tacrolimus, but I've never seen a patient on PPI develop such a severe hypomagnesemia. Now I do have a question from one of our audience members, Dr. Maria Cordero. And she's asking about some of the other nutritional markers. She specifically is asking about the vitamin D level. Did you check any other markers of nutrition, such as vitamin D for this patient? Is it possible that she was malabsorbing more than one electrolytes or nutrient because with PPIs, we're also taught a lot about dysbiosis. By suppressing acid secretion and raising the stomach pH, you're creating an environment that's conducive to a more aberrant microbial flora. And that can lead to malabsorption as well. There's no easy way to check for dysbiosis, but was this specific to magnesium, do you think? And did you look at any other nutritional markers such as vitamin D?
That's an excellent question. I have to plead the fifth here. I was so focused on the severe hypomagnesemia and trying to fix it in time to get this woman her breast surgery that I didn't really focus on other markers of nutrition, though she may very well have had other nutritional deficiencies. I'm not, however, aware of the PPI is predisposing towards or leading to malabsorption of other nutrients. So I don't, I didn't check for that. I sort of focused on the magnesium itself, but perhaps she did.
Yeah, zinc is the one nutrient that I've seen low in patients with dysbiosis.
Was she
oftentimes-
hypocalcemic? Sorry, was she hypocalcemic?
She was not. She was not happy. I mean, by the time I saw her, magnesium was reasonably normal from the IV infusions that she was having regularly. So she had neither hypokalemia or hypocalcemia.
I mean, noticed that her phosphorus was low because it almost tips over into refeeding sometimes, especially with poor PO intake in general. And maybe the magnesium is the first to show if they have a PPI or a CNI or diarrhea from their mycophenolate. But I can sometimes see low phosphorus, and it gives you a clue of whether they're having poor PO intake and whether it's short-term or long-term. And then when you start to replete them, as you said, the IV mag can wash through, but if you're repleting them orally aggressively, they're going to reach this gut absorption threshold, right? Which is why you chose slow magnesium. But even I think if you dose it appropriately and they're tolerating it, can't it take an extended period of time to replete their total body magnesium? Isn't there some overlap where the bone does have to restore its stores of magnesium?
My understanding is that that magnesium is a little bit different than, let's say, potassium, which readily is exchanged between the intracellular and extracellular compartments, and that magnesium, since most magnesium is stored in bone, it's really almost like a separate compartment, and it's much slower in terms of equilibrating with the intravascular compartment. So I don't know the answer to that. It didn't take that long, and maybe it was just the PPI and the magnesium supplements in combination that really treated her, that allowed her magnesium to rise. But there was no delay, really. I mean, it really remained within the normal range throughout the entire time I was treating her.
I got another one, Allon. She was on alendronate, right?
She was on alendronate.
Yeah, because that's also listed as something that can be linked to hypomagnesemia, and it goes to this bone issue that you're saying, that it's really bound in bone, and I think it's a drug that binds magnesium. I mean, it's something that deposits in the bone, and it can bind magnesium. So sort of an interesting thought. Based on the success you've had with her treatment, I don't think it played a major role, but it's something that may be worth mentioning.
Yes, thank you for that.
I think we're all going to be checking magnesium levels a little more frequently going forward, especially if they are on proton pump inhibitors. I certainly will be looking at even more. I think this is really what distinguishes physician nutrition specialists is we care to know these little details that I think other physicians would not consider. So really, I want to first of all congratulate you on an excellent presentation and bringing an excellent case to our attention. And I want to thank our panelists for contributing and for adding some excellent insights and questions. We continue to do nutrition rounds quarterly, and we will continue to invite directors or diplomats of our board to present cases where medical nutrition played a role in their therapy and in their patient care. And we always will try to gather a panel of experts to contribute. But I have one other comment, a few other comments. If anyone else wants to participate from the audience, Dr. Dean Omer says, excellent talk, thank you. This is especially under-recognized when considering how widespread the use of long-term PPIs is now. And I think PPIs are the second or third, I think it's the third most commonly prescribed medicine in the US. I think thyroid medicine and some blood pressure medicine are 1 and 2. So PPIs are a very important tool in our toolbox for patients that have upper GI symptoms, reflux and heartburn, indigestion, functional dyspepsia. And I think, again, we should be checking electrolytes a little more carefully when we do keep patients on these host of medications. And let's see, any other comments from the audience? Dr. Rothkopf, thank you. Mike, he says, great talk and discussion, thank you. And Ruba Abdelhadi also sends her congratulations and thank you. So at this point, first of all, I forgot to introduce myself. I'm Daron Kahana. I'm the current president of the National Board of Physician Nutrition Specialists. And with that, I would like to thank everyone. We have a couple of minutes left. Any other last thoughts?
Doran, as a medical student, I was told by Bud Relman, who became the editor of the New England Journal, who was a very thoughtful, brilliant, but self-involved physician, who used to tell the students at Penn that in most humans, the renal cortex was the brightest in the body. So when we talk about why nutrition is so complex, a lot of it does come back actually to the brain and understanding that. So a thought for a future conversation is to drag in one of the gentlemen that, and I know a couple that are at the forefront of understanding the brains, who are neuroendocrinologists, neuroscientists, the brain's control of everything from appetite to energy to water to salt, and might even have some idea about, what the mechanisms are for these other electrolytes and whatnot. Because we're all going to eventually have to think this way, because it comes back to the brain. That's why we're here.
Yeah.
Good discussion.
Excellent. And I think tree nuts, by the way, are very rich sources of magnesium, pistachios and almonds, and another reason to munch on those when we can. So thank you again, Dr. Friedman. Excellent presentation. And thank you,
Very
Dr.
welcome.
Anderson, Dr. Kovesty, Dr. McCarran. And thank you to our audience for taking the time and participating. And we will now close this quarterly nutrition rounds, and we will reconvene with our monthly meeting. Thank you very much.
Thank you.